There's still much debate about how formulation differs from diagnosis. Formulation and diagnosis are said to serve different functions. Diagnosis is based on a medical or biological model, whereas formulation has its origins in a psychosocial model. Psychiatric diagnosis is largely descriptive and does not assume etiology, whereas formulation is concerned with explaining why a client presents to therapy at a particular point in time and how an individual came to develop these presenting problems. Psychiatric diagnosis is atheoretical, while formulation is concerned with linking psychological theory to explain problems. Diagnosis has also been described as an exercise of naming what a particular patient has in common with others. It is generic compared to formulation, which attempts to identify and explain what is unique or idiographic about an individual's presentation. Although psychiatric diagnosis allows the psychiatrist to match the diagnosis to the treatment, for example, a depressed person takes antidepressants, in psychological interventions, however, diagnosis by itself remains a poor way of choosing an effective treatment due to the purely descriptive nature of diagnosis. Formulation, on the other hand, provides a blueprint of specific targets to be addressed during treatment in order for the problems to be resolved. Finally, while diagnosis is a pronouncement of a disease by an expert, formulation is developed collaboratively between the therapist and the client and is considered a plausible account of a client's difficulties rather than as the gospel truth. Extensive research has been conducted on how individuals perceive psychiatric diagnoses. In particular, individuals who have been given a psychiatric diagnosis have been reported to internalize these labels such that they have a bearing upon subsequent behavior. A patient exhibits erratic behavior because he or she is supposed to be mad. Psychiatric patients see themselves as victims of a disease which they have no control and responsibility over. Psychiatric diagnoses have been also criticized for reducing self-efficacy and for leading patients to be reliant on medical professionals for the treatment of their mental illnesses. Stigma is also commonly associated with psychiatric labels. People with a diagnosis such as schizophrenia or bipolar are often seen in an unfavorable light. They are viewed as dangerous, unpredictable, and untrustworthy, even in the absence of bizarre behaviors. These negative attitudes towards psychiatric patients often lead to the social rejection of these individuals. Although disease-based explanations for mental disorders have been argued to promote greater understanding and acceptance, results of studies on the stigma associated with psychiatric labels do not suggest that this is so. In fact, a disease-based explanation for mental disorders failed to improve attitudes towards psychiatric patients. Respondents in the study continued to hold negative attitudes towards mental patients, deemed them to be dangerous, and expressed reservations about living next door to them or being romantically involved with one. Psychiatric diagnoses have also been criticized as dehumanizing, as it fails to take the personal meaning of an individual's problem into account or to put problems in a context where the problems are seen as understandable. Finally, due to the stigmatizing and dehumanizing effects associated with psychiatric labels, diagnosis is criticized as being counter-therapeutic to the therapeutic relationship, which is supposed to instill hope in the client that change is possible. In summary, although discrete diagnostic categories are meaningful in medicine because medical diseases exist as discrete and separate entities, the same cannot be said of psychological and emotional disturbance, as feelings and behavior do not come in neat little packages. Thus, mental disorders cannot be diagnosed in the same way as medical disorders. In summary, psychiatric diagnoses are derived from the medical model of classifying physical diseases. Psychiatric diagnoses are a way of categorizing and describing a set of symptoms that have been criticisms against psychiatric diagnoses, as these labels can often be experienced as stigmatizing and dehumanizing. Psychiatric diagnoses are limited in and of themselves in terms of informing psychological treatment. Because diagnoses are not very helpful, formulation has been suggested to be an extension or as an alternative to diagnosis in guiding psychological interventions. Some proponents of formulation have argued that diagnoses become redundant if psychiatric symptoms are rendered as understandable responses to overwhelming life circumstances through the process of psychological formulation. In the words of Bentel, once these complaints have been explained, there is no ghostly disease remaining that also requires an explanation. Complaints are all there is. However, there has been criticisms against formulation as much as there has been criticisms against diagnosis. Formulation has been largely criticized, in particular, as the reliability, validity, and quality of formulations tend to be variable. Research has suggested that clinicians tend to agree on what are the here and now problems that a client presents with, but that they tend to differ in terms of identifying what the client's deeper beliefs are. So as the formulation goes deeper, the level of agreement between clinicians tends to vary. Also, not surprisingly, the quality of formulations have been associated with the length of training and experience of the therapist. The formulations of experienced psychotherapists tended to be more comprehensive, elaborate, complex and systematic compared to that of novice psychotherapists. Heuristics and biases of the psychologists have also been criticized as being influential in affecting formulations. However, it could be argued that formulation could be better thought of as whether it is useful in moving a client towards change and in informing intervention rather than as being reliable. Although two therapists could have contrasting formulations about the origins of a client's problems, both formulations could be equally valid and lead to positive outcomes. Also, while experience and length of training affects the quality of formulations, both novice and experienced psychotherapists can continue to hone their formulation skills through continued training, reflective practice, and supervision. Another argument against formulation includes research showing that some clients experience formulations negatively. Payne and colleagues conducted a study to examine clients' reactions to psychological formulation. They noted that clients had emotionally complex reactions to the formulation of their problems, with some clients experiencing formulations negatively. Similar findings were also obtained by Leeming and colleagues, who found that their clients preferred diagnosis over formulation, as diagnosis provided a justification of their difficulties and allowed themselves to be viewed as victims of biological processes instead of persons who were responsible for their distress. However, as was discussed earlier, more often than not, diagnoses are stigmatizing and can lead to social rejection. Also, when clients experience formulations negatively, this need not imply a lack of value of formulations. The client's negativity could possibly be a healthy response to the content of formulations. It could also be a sign that the client is drawing unintended conclusions from the formulation, thus signaling to the therapist that the client could have misinterpreted the formulation because of the way that the formulation was communicated. Thus, in order to help the client feel more at ease with formulations, therapists need to identify ways in which they can help clients develop a coherent narrative of their problems in a way that is socially acceptable, and to be sensitive in communicating formulations to clients so that they don't feel unduly distressed. Lastly, there has been increasing interest in the efficacy of manualized treatment versus individualized formulation-driven interventions. While the research on manual-based treatment interventions and case formulation interventions is not yet clear, there will still be a need for formulation-driven interventions, as manual-based interventions are often not available for complex cases involving comorbid disorders. In clinical practice, clients often present with multiple problems rather than a clear-cut depression or anxiety. Also, comparing between manualized treatments and formulation-driven treatments in order to establish the efficacy of formulation is fraught with many challenges. It is difficult to tease apart the effectiveness of the formulation from the treatment effectiveness. The formulation could have been well and effective, but if the intervention was not carried out in an effective manner, it could also affect client outcomes. In summary, formulation skills as well as intervention skills are necessary in clinical work and cannot be independent of each other.